Okay, fantastic. Let's make a start. So, thank you all for joining today. For those that don't know me, I'm Devansh. I'm a foundation doctor based in the Midlands. I graduated from UCL in July 2025. I've got a strong interest in ophthalmology as well as other surgical specialties. And so today I'm here to deliver a talk about retinal conditions that should be particularly useful for those of you sitting the UKMLA. So whether you're a final year or you are a medical student earlier on in your journey, this should still be useful for you as everyone will be sitting the UKMLA at some point. I'd like to make this as interactive as possible. So if you've got any questions, feel free to drop them in the chat box. And alongside that, there'll be some SBAs. If you could engage for those SBAs through dropping your answers in the chat box, that would be fantastic as well. And as I said, any questions that you've got, feel free to fire away. We'll try to answer them as much as possible within the talk itself, as we're going through the slides, if not at the end. All right, so let's make a start. So the key things that I'd like you to try and achieve by the end of this session is to be able to recognize some of the red flag symptoms for retinal conditions, to be able to differentiate between common retinal conditions like posterior vitreous detachment, and the difference between that and retinal detachments and tears, differentiating between central retinal artery occlusions and vein occlusions, differentiating between dry and wet AMD, as well as the varying pathologies for diabetic retinopathy, including non-proliferative, proliferative, and diabetic macular edema. We'll also work on how to go about choosing the right investigation first, how to go about triaging the urgency of the condition that's in front of you. And of course, we'll talk about management for these conditions as well. So for each condition, there'll be an SBA. We'll go through some risk factors, pathophysiology, as well as delving into the presentation, investigations, and management. If anyone hasn't seen this, you can access it using the link that I've provided here. So this is from the official curriculum map for ophthalmology, for the UKMLA, in fact. It's got a section on each specialty, including ophthalmology, as you can see here. So this is quite comprehensive, and this is what I would use to kind of tailor your revision based on, as these are the high yield conditions and presentations that you're going to be assessed on. So looking at the conditions down the right-hand side, you can see a lot of them are retinal based. So that's what we're going to be covering today. And there will be subsequent sessions over the coming weeks and months that will cover the other conditions listed here as well. So without further ado, on to the first SBA. A 66-year-old myopic patient presents with sudden onset flashes and a shower of new floaters in one eye. His visual acuity is maintained at 6/6. There's no pain, and on examination, there's no visual field defect. What is the most appropriate next step? I'll give you all around a minute or so to answer this using the chat box. Okay, so the answer here was B, and the condition that this is referring to is posterior vitreous detachment. So I guess the question that we need to answer next is why? Why was urgent dilated fundus examination to rule out retinal tear or detachment the best answer? And the reason being, PVD itself is common and usually benign, but the key danger that's associated with it is further retinal tears or detachment, and we'll have a look at why in a second. So this patient will typically present with new flashes and floaters, often seen in one eye, unless of course it's bilateral, although that's quite rare. And the key thing to do is to refer this patient for an urgent examination of their retina, either through a fundoscopy, which can often be done in the GP setting, but more reliably through a slit lamp, which will be done by an ophthalmologist or an optometrist, to try and pick up whether this is indeed just posterior vitreous detachment or whether there's a more sinister pathology like retinal detachment going on alongside this. If, for example, this patient doesn't have retinal detachment, then it would simply be a case of safety netting them and making sure that if any further symptoms or worsening of symptoms occurs, then they present back as soon as possible and seek medical advice. So a bit about the pathophysiology for posterior vitreous detachment. Why does this happen and what are the risk factors? Let's delve into that. So the key risk factors are age and being very, very nearsighted, what we call high myopia. We'll talk about why. So what age does over a period of time is makes the vitreous thinner, and this leads to a shrinking of the vitreous, which is the gel towards the back of the eye. As it starts to shrink, it starts to peel away from the retina itself, and this is called posterior vitreous detachment. So that traction that you get on the retina from the vitreous shrinking and pulling on it and tugging on it causes the photopsia or the flashes that we're describing, and clumping of this vitreous as it shrinks is what results in the floaters. So if the vitreous is attached at various parts of the retina quite strongly and it shrinks, this can lead to a retinal tear. And once there is fluid that is able to seep underneath this retinal tear, that can lead to a retinal detachment. So that's why recognizing PVD it may have occurred is very, very important. PVD in itself won't lead to visual loss, but retinal detachment certainly can. So it's very important to be aware of and to safety net your patient accordingly as well. In terms of why high myopia or being nearsighted contributes to this, it's a similar sort of principle. So when an individual is very nearsighted, the eyeball is often a lot longer. And what this does is it actually causes the vitreous to shrink a lot more as well, comparative to the size of the eyeball. And that ultimately leads to traction on the retina and increases the risk of tears going forwards and detachments going forwards as well. So primarily due to the length of the eyeball, that's why that is also a risk. Coming on to the presentation and investigation, so fairly straightforward. We've discussed flashes, floaters already. There's no pain often involved here. The visual acuity is often not impacted and often normal. However, red flag symptoms to be aware of are visual field defects emerging or the patient describing a curtain descending over their vision. So in terms of investigations, what we'd want to do is a full ophthalmic bedside examination. This would include everything, including assessing visual acuity, visual field defects, the reflexes such as accommodation, and also the corneal reflex, as well as the pupillary reflexes and RAPD. You'd also want to assess hemi-neglect. However, the key things that we want to focus on are, of course, acuity and visual field defect before performing further investigations. So we'd want to refer straight away, really, for urgent retinal assessment. The way in which it would then be assessed would be through dilation of the pupils, a fundus examination through a fundoscopy, or a slit lamp examination to better visualize the retina. That will be able to give us an idea of whether there is just a detachment of the vitreous or whether there's retinal detachment too. So the second SPA, I'll give you all a minute or so to answer this. So a 59-year-old reports flashes and floaters for 24 hours, followed by a painless curtain descending over the temporal field of vision. They had cataract surgery 6 months ago. What is the most appropriate management? So I'll give you a minute to answer this. Okay, so the key thing here is emergency same-day ophthalmology referral for suspected retinal detachment. So this is, in fact, a retinal detachment because this patient has got that curtain or that visual field defect. Often in ophthalmology, in that context, if a patient comes into the clinic or the GP setting complaining of a curtain over their vision or a visual field defect as described, it's often a retinal detachment, and that's a key differential to be aware of. There are other differentials for visual field defects, which would, of course, be extremely important. When this happens suddenly, we have to think about things like amaurosis fugax or a TIA/stroke. However, in this context today, we're primarily focusing on retinal detachment. There are two types of retinal detachments that we need to be aware of. Some involve the macula and some do not involve the macula. When the macula is not involved, that is what we call time critical, because the central vision has not yet been lost. And so there is a chance that if we're able to get this patient into the operating theatre as soon as possible, we're actually able to restore their vision and prevent a decrease in their visual acuity. If the macula has already been impacted, then that is, of course, not as urgent as you'd think, because the likelihood of actually improving that patient's vision is much lower when compared to the macula still being unaffected. And so that's an example of how you'd prioritize which patient to get into theatre as soon as possible. Of course, we don't want to delay imaging. We want to make sure that assessments followed by a dilated fundoscopy, as we've mentioned, is done as soon as possible, and hence emergency referral is the key thing here. So coming on to pathophysiology and risk factors, our risk factors are very similar to what we saw for PBD, high myopia, as we discussed. Trauma can also lead to retinal detachments. Previous retinal detachments can lead to an increased risk of further detachments going forwards. And of course, post-cataract surgery is a risk factor too, which is why we mentioned that in the vignette. In terms of the pathophysiology, the most common type of retinal detachment is rhegmatogenous retinal detachment. So this is exactly what we've described, where a retinal tear leads to fluid entering that particular space, and then we have a retinal detachment that happens subsequently. There are other types of retinal detachments. You don't need to know them in as much detail for the UKMLA, but tractional retinal detachments can occur due to the formation of fibrovascular membranes, which are essentially a combination of fibrous tissue and new vessels that form at the retina. That can lead to an increased traction on the retina itself and therefore lead to detachments. And if, for example, a patient has a tumor or there is inflammation ongoing, then exudative retinal detachments can also lead to that fluid accumulation and contribute towards the retina detaching without any fluid accumulation. It's without a tear itself. But for UKMLA purposes, the primary thing to focus on is PBD, then predisposing to retinal detachments occurring. Presentation and investigation, so similar sort of thing to what we've discussed previously, but including the painless curtain or the visual field defect that you'll see on top of the flashes and floaters. Visual acuity can be affected if the macula is involved. And so when we're doing our examination, we want to really focus on field defects and visual acuity. Slit lamp examination and dilated fundoscopy will also be very important. And what you'd often see on a slit lamp is what we call Schaeffer's sign or tobacco dust. This is where we see cells floating around in the anterior portion of the anterior segment of the vitreous itself. Okay, that's an indication that we've had cells from the retina detach and then are floating around in that space. That's a classic sign of retinal detachment that you'll see on slit lamp. If you're not able to perform an effective slit lamp examination, or the ophthalmologist is not able to perform an effective slit lamp examination for whatever reason, then we can use an ultrasound scan to confirm the detachment as well. Coming on to management, so this is immediate, urgent ophthalmology review. We can also then treat this in theatre through a variety of different techniques. We've listed some of the techniques here below. You don't need to know this for the UKMLA in a huge amount of detail, but it's good to know that we can either use lasers or we can use cryotherapy alongside other techniques such as gas tamponade as well as scleral buckling. If you're looking to sit the Duke Elder exam, then knowing these management types and when they can be used and the benefits of them is incredibly important. But for the context of UKMLA, just a brief awareness is probably good enough. Macula on versus macula off, we've already described. So any further questions regarding those, feel free to drop them in the chat and we'll take it from there. So our third SPA, we're going to move on now. We've got a 62-year-old man with type 2 diabetes who has gradually worsening central vision. Fundoscopy shows macular hard exudates, and OCT confirms that this patient has central macular edema. Which treatment is most likely to improve their vision, given the context that we've described here? We'll give you all about a minute or so to answer this. Okay, so this condition is diabetic macular edema. That image on the right-hand side is optical coherence tomography and OCT scan, which is showing us the different layers of the retina, showing us the presence of diabetic macular edema. So what is this, and why are intravitreal anti-VEGF injections useful? So diabetic macular edema occurs when ischemia leads to leakage of fluid from new vessels that are formed, and that can present as this edema that we see, then causing various symptoms that we'll come on to discussing in a second. So, anti-VEGF is a key treatment for improving vision loss in DMO. We'll look into why that is in just a moment as well. The really important thing for you to understand for the UKMLA is when to use anti-VEGF and when to use panretinal photocoagulation, which is PRP. We'll have a look at the differences and why that is in just a moment. So, coming on to diabetic retinopathy more generally, why does this actually happen? It's due to chronic hyperglycemia causing our basement membranes of our capillaries to thicken, and this leads to the formation of various microaneurysms. In addition to this, we can get leakage happening from our vessels, which contributes to the edema we had discussed, and the leakage also leads to the formation of hard exudates. On top of that, if we have ischemia ongoing, then what our body does to try and compensate the ischemia is to upregulate VEGF. And this leads to what we call neovascularization, the formation of new blood vessels, which have the tendency to leak and bleed a lot more than our existing blood vessels. And that's, of course, a big problem that we'll look into. So there are different ways to categorize diabetic retinopathy. We can broadly categorize into non-proliferative and proliferative. Non-proliferative diabetic retinopathy takes place prior to the formation of new blood vessels, that neovascularization that we were talking about. The key things that we would see on fundoscopy or on slit lamp examination when we're looking at the retina would be these microaneurysms. We would see small hemorrhages that we refer to as dot blot hemorrhages. We would see hard exudates and soft exudates. On the other hand, proliferative diabetic retinopathy, we would expect to see neovascularization, so the formation of new blood vessels. That increases the risk of vitreous hemorrhage, which we'll look at as a separate condition in a few minutes' time. Diabetic macular edema, again, is another type of presentation that we could see, again, due to the leakage that we see occurring from the blood vessels. So this is a slide just showing us the difference between non-proliferative and proliferative diabetic retinopathy. On the left-hand side, we can see lots of soft and hard exudates, as well as some microaneurysms and hemorrhages dotted around. On the right-hand side, we see proliferative diabetic retinopathy. Again, we've still got those exudates, we've still got those hemorrhages, but what we also see, like you'll be able to appreciate, is a lot more new, smaller, fragile-looking vessels that are formed in comparison to the left-hand side over here. So that is a key example of proliferation, neovascularization, and those new blood vessels that are formed there in response to the ischemia are particularly high risk for leakage and bleeding. Presentation and investigation. So for diabetes and diabetic retinopathy, screening is incredibly important because often patients are asymptomatic and the disease silently progresses in the background without causing any symptoms before it reaches a point where it's very severe and advanced, and then the patient's chances of recovery of vision are quite slim. So a gradual decline in visual acuity is what you'd expect. Alongside this, if a patient has macular edema, then we'd expect their central vision to be affected the most. So to go about investigating this, we'll start off with a full bedside examination for ophthalmology, as we've discussed previously. We'd want to do some bloods, have a look at their HbA1c levels, lipid profiles, renal function, as the kidneys can also be affected in diabetes quite significantly. We'd move on to then, as we've discussed previously, and as is the trend with the retinal conditions, doing a dilated fundoscopy and a slit lamp examination. We can then actually do an OCT, which we saw earlier an image of on the right-hand side, looking at the retinal layers, and that will really help us to confirm whether there is macular edema or not. And finally, we can also perform an investigation called fluorescent angiography, where we visualize the blood vessels in more detail to identify areas that are leaking and also that will assist us with treatment planning, which we'll come on to discussing in a moment. So coming on to management, the treatment for non-proliferative versus proliferative diabetic retinopathy varies. So for non-proliferative, the key things that we want to do is to prevent further progression. So this is through risk factor control, like diet and exercise, controlling blood pressure, controlling lipid levels within the blood, and of course, stopping smoking. In terms of proliferative diabetic retinopathy, this is quite an interesting method that we use to treat. So what we want to really do here is to try and decrease the ischemia that is ongoing at the retina, because that's the primary reason we've had the neovascularization take place in the first place. So we can use a technique called pan-retinal photocoagulation, which is a fancy way of just saying we're going to burn various cells within the retina. That's going to decrease the oxygen demand of the retina as a whole, and therefore, in theory, decrease the ischemia, and therefore help to decrease the proliferation of these new blood vessels that are forming, and sometimes even help to regress the new blood vessels that have formed as well. Diabetic macular edema can be treated through intravitreal anti-VEGF injections. So this is another way that we can help to decrease further proliferation from taking place, is to actually just stop the growth factor that's leading to the proliferation of blood vessels in the first place. Key thing to note here is that this neovascularization that we're taking place, the reason why it's such a big problem is because it increases the risk of bleeding, leading to things like vitreous hemorrhages. And it can also increase the risk of retinal detachments going forwards as well. So coming on to our fourth SBA, we have a 58-year-old man with long-standing type 2 diabetes presenting with sudden onset floaters and blurred vision in his right eye. There's no pain, and on examination, the red reflex is reduced, and you can't obtain a clear fundus view. What is the most appropriate next step? We'll give you a minute or so. So the key thing here is, again, answer B, same-day ophthalmology assessment with dilated exam. If the fundus view is obscured, we can perform a B scan, as we've said, the ultrasound, to rule out retinal tear and detachment. The reason this is because the condition that's being described is, in fact, a vitreous hemorrhage. So a vitreous hemorrhage can cause painless floaters and blurred vision, and therefore mask a retinal tear or detachment going on in the background. And that's why we want to actually perform dilated fundus examination to see if we can see the retinal detachment or not. If we're not able to see it, then we can perform that B scan ultrasound to try and see behind and get a better view of if there's a detachment present or not. Vitreous hemorrhage itself, why does it happen? So what's going on? It's bleeding into the vitreous cavity that happens from the retina or the optic disc's vessels. And that bleeding into the vitreous cavity is what leads to that hazy vision that we see in that reduced red reflex. Common causes, proliferative diabetic retinopathy, as we've discussed, leads to those neovascular new blood vessels forming that are prone to leakage and hemorrhage. Posterior vitreous detachment with retinal tears can also lead to rupture of blood vessels and lead to this hemorrhage. Central retinal vein occlusions can contribute, and trauma are also big contributors in younger patients. So risk factors, as we've discussed, diabetes leading to proliferative diabetic retinopathy, being considerably nearsighted, high myopic, leading to risks of retinal detachments. Trauma or recent intraocular procedures can increase the risk of hemorrhages. Previous tears and detachments, and of course, anticoagulant and antiplatelet therapy is something to be aware of, as if someone has a vitreous hemorrhage, it's likely to be a lot worse if they're on these medications. In terms of presentation, key thing to note is that sudden painless loss of vision with floaters. You may well have flashes and floaters if there's ongoing retinal detachment there as well. And you may well have visual field defects if it's associated with that detachment that we discussed before as well. So the key thing really is that loss of visual acuity, plus minus the additional symptoms like flashes, floaters, and decreased visual acuity. Full bedside examination, absolutely crucial once again. Fundoscopy, very, very important once again. Quite likely that the fundus view may be blocked by the hemorrhage itself, as of course, the vitreous is in front of the retina. So if we have a hemorrhage there, it may well block the retina view, and therefore we can then perform an ultrasound scan to try and rule out other detachment going on behind the vitreous. Key thing to note here is that we again want urgent same-day retinal assessment. Assessment, as vitreous hemorrhage can hide that detachment we've been talking about. In terms of treatment, if our treatment, if it's because of proliferative diabetic retinopathy with that neovascularization, there's new blood vessels that are formed, again, we can contribute to the treatment with PRP, the pan-retinal photocoagulation. If there's an underlying tear in the background, then we can, of course, take the patient for surgery into theaters. And if, despite all of this, our vitreous hemorrhage isn't improving, then we can perform a vitrectomy instead, which is just removal of the vitreous itself. Key thing to always ask for these patients is why. Why have they had a vitreous hemorrhage in the first place? It's often due to a pre-existing cause like detachments or neovascularization that we've discussed. So our fifth SBA, moving on. So a 78-year-old female notices a new distortion of straight lines and a central gray patch in one eye. Fundoscopy shows macular hemorrhage and subretinal fluid is seen on optical coherence tomography. What is the most appropriate management? I'll give you all a minute again. So the key thing here is urgent referral for intravitreal anti-VEGF therapy for suspected wet AMD. So wet AMD is the condition in question here. And we'll come on to looking at the difference between dry and wet AMD in a few moments' time. But the key thing to note here is the reason why this lady has got blurred vision and distortion of straight lines is due to the macula being affected. So we call this metamorphosia. All right, that's the distortion of those straight lines we've been discussing. Plus minus, we can also get macular hemorrhage taking place because of further neovascularization that occurs during wet AMD. So we'll discuss why dry AMD leads to neovascularization and hence wet AMD in just a second as well. Wet AMD itself can cause rapid loss of visual acuity, and anti-VEGF injections can improve or maintain vision in many patients, and that's why it's incredibly useful. Dry AMD is managed differently, which we'll have a look at in a second. So let's start with dry AMD because it's often a progression into wet AMD, and the whole thing is really a spectrum. So it's best to start at the beginning of the spectrum, dry AMD first. Everyone knows that dry AMD has a drusen. That's the buzzword that's used, but what actually is drusen? It's a series of deposits that are often lipid and protein rich that accumulate around the macula. They specifically accumulate under the retinal pigment epithelium, which is one of the key layers within the retina that you are able to visualize on OCT. Due to this accumulation of these deposits, we get damage to the photoreceptors at the macula itself, and this can progress to what we call geographic atrophy, where we end up having irreversible central visual loss if this is an advanced stage of disease. So risk factors for the formation of this drusen and this leading to this dry AMD is age, by far the biggest factor. Patient's sex can also contribute, females being at more risk. A history of smoking, as well as a family history, and strong cardiovascular risk factors can all play a big role in the deposition of these lipids and proteins under the retinal pigment epithelium. Coming on to the presentation itself, so with dry AMD, we see a gradual decline of visual acuity, leading to central visual loss, blurred faces, straight lines appearing curved. These are your classic buzzwords you'd expect to see in an SBA. We would do a full bedside examination for this, including the Amsler grid, which will really help us to assess whether a patient is seeing straight lines as curved or not. Fundoscopy and slit lamp is again very helpful to help us pick up on the drusen and the geographic atrophy around the macula. And OCT can be helpful to actually stage the disease and assess whether we've had conversion to wet AMD. Because when we get wet AMD, we get the accumulation of fluid, leakage of fluid. We also get the formation of new blood vessels that are likely to bleed, all of which can be picked up through OCT. How would we go about managing dry AMD? The key thing here is to stop smoking if the patient is smoking, to decrease cardiovascular risk factors, and to consider some vitamin supplements. So, in particular for vitamins A, C, and E, and zinc, these supplements are incredibly helpful to try and decrease the progression of dry AMD. What we'd really want to do is to safety net them as well. Let's say a patient is picked up in clinic with having dry AMD and they haven't had conversion to wet AMD yet. If they had a sudden deterioration of their visual acuity, we would want them to come into the clinic or to eye casualty as soon as possible so that they can then be treated accordingly. So moving on to wet AMD and how it differs from dry AMD, it's a progression. So when dry AMD leads to ischemia and neovascularization, the formation of these new blood vessels, we again see something similar to what we've seen with proliferative diabetic retinopathy, where these blood vessels that are formed are quite fragile and weak, and they're prone to leakage and bleeding. This leads to the accumulation of subretinal fluid and hemorrhage, which leads to rapid central visual loss. Central visual loss rather than generalized visual loss, because of course this is all happening at the macula itself. Presentation, we've already discussed reduced visual acuity, straight lines appearing blurry, metamorphosia as we've discussed. Investigations wise, OCT is absolutely crucial here. Fluorescent angiography can be very helpful as well to characterize where the neovascularization is taking place. Management, we want to refer these patients urgently to a retinal service for intravitreal anti-VEGF injections, which will, of course, help to try and decrease the VEGF growth factor that's contributing to the neovascularization in the first place. So the key thing is that wet AMD is time sensitive. And so for the best outcomes for these patients, we want to refer them as soon as possible. And the national guideline for treatment is, in fact, patients with suspected wet AMD should be receiving their intravitreal injections within 2 weeks of referral from the community. So that puts things into perspective. The 2 weeks is incredibly crucial to helping these patients have good outcomes going forwards. Moving on to our next SBA. So we're looking at a different condition here. The image on the right-hand side might give it away. So we've got a 72-year-old gentleman presenting with sudden, painless, profound monoocular vision loss. So just in one eye, where they've completely lost vision quite suddenly. This exam that we do shows a relative afferent pupillary defect, and fundoscopy reveals a very pale-looking retina, as we can see on the right-hand side, with a cherry red spot in the middle. What is the most important immediate next step? We'll give you a minute to have a think. Okay, so this is an example of central retinal artery occlusion, and hence the most important thing is option A, urgent stroke center assessment and vascular risk workup. Reason being, this is essentially a form of either an embolus or a thrombus getting stuck in the central retinal artery. So that's what's causing our sudden visual loss here. And acute retinal ischemia that is caused because of an embolus or a thrombus in the central retinal artery is in fact treated as a stroke equivalent, because this patient will also have risk factors for strokes and TIAs as well. So key thing to consider on top of all that is one of the differentials here. If a patient has sudden visual loss of this particular nature in their eye, and let's say they also have a headache or jaw claudication on top, then we have to consider things like giant cell arteritis, especially if we've got an elderly patient with us. Pathophysiology, let's have a chat about that. So acute arterial occlusion leads to that retinal infarction we've discussed, which is why we get such a pale retinal appearance. The reason why we have a cherry red spot is because that is representing the fovea. And the fovea's blood supply is actually different to the rest of the retinas. Hence why the central retinal artery, when it's occluded, will lead to the entire retina except the fovea appearing pale. We'll have a look at what the blood supply to the fovea is in just a second as well. So the most common cause of central retinal artery occlusion is an embolic or thrombotic event, either due to carotid atherosclerosis or a cardiac emboli. Less commonly, it can be due to arteritis such as GCA or a hypercoagulable state as well, such as a patient with thrombophilia, as well as other causes. So the key risk factors here, atrial fibrillation, a big one for the formation of these emboli. That again, it can increase the risk of limb ischemia, can increase the risk of strokes. In the same way, it can increase the risk of central retinal artery occlusion as well. Age, hypertension, diabetes, smoking, hyperlipidemia, all of the classic metabolic syndrome risk factors that you can think of would contribute to an increased risk of CRAO. Having a look at the right-hand side, we can see some anatomy here. We'll just do a quick recap. So the central retinal artery that's occluded here, it originates from that ophthalmic artery that you can see there. Now, the reason why our fovea still has blood supply and therefore appears red as a cherry red spot is because it in fact gets its blood supply from these posterior ciliary arteries we can see here, which give rise to these short posterior ciliary arteries. So the origination of the blood supply for the fovea is in fact different to the rest of the retina, and that's why we still have a cherry red spot rather than that being pale as well. Presentation investigation. So the key thing is that we have a sudden painless, severe monoocular visual loss. These patients' visual acuity is often very, very low to the point where Snellen's chart is pointless and they're just able to count fingers. They may not even have any light perception altogether. So a full bedside ophthalmic examination is very important. In addition to that, we want to perform neurological examinations of the upper limbs, the lower limbs, cranial nerves, because even though this patient's had a retinal artery occlusion, there's no reason why this patient wouldn't be at risk of strokes going forwards or may have already had a stroke before. So very important to assess that. ECG is important because AF is a big risk factor here. ESR is important because sometimes CRAO can be caused by GCA. And so if we have a patient who has the risk factors and has that jaw claudication and headache we discussed earlier, it's very important to rule that out. And of course, a CT angiogram would be very important to try and characterize whether there is stenosis of the carotid arteries, which may be contributing to this as well. Management-wise, we want to effectively treat as a stroke, so emergency referral and secondary prevention is very, very important. These patients will often be put on antiplatelet therapy and statins going forward as well. Your classic aspirin, clopidogrel 75 milligrams, and your atorvastatin 80 milligrams would be very useful here. There's no real high-quality evidence suggesting that we can do an ocular maneuver that will help to get rid of this emboli or thrombosis. And therefore, we want to just go ahead and treat as we would with an ischemic stroke. If GCA is suspected as a cause, if that patient has the risk factors we've discussed, high-dose steroids would be very useful. And we don't really want to wait around for a temporal biopsy. In that case, we'd want to crack on with our methylprednisolone. SBA 7. So we have an 80-year-old female with hypertension presenting with sudden painless blurred vision in one eye. Fundoscopy is showing dilated tortuous veins, widespread retinal hemorrhages, and cotton wool spots, similar to the appearance that we can see on the right-hand side. Once again, we'll give you a minute or so to answer this question. So the condition in question here is central retinal vein occlusion. a slight variant to the central retinal artery occlusion that we'd seen previously. And if this patient with CRVO has macular edema as well, then anti-VEGF injections would be very helpful. So this is a question which links together what we've learned previously about macular edema and CRVO, combining them together, and therefore anti-VEGF injections would be beneficial for this patient. So macular edema is the commonest cause of reduced vision in CRVO. What's actually happening in CRVO? Well, we have a blockage in our central retinal vein, which is leading to backflow of blood and decreased drainage of blood from our retina. That's then increasing the pressure within these blood vessels, leading to leakage, hemorrhages that we all see on the right-hand side. And so similarly, anti-VEGF therapy will help to prevent and decrease new blood vessels from forming, and will actually help to decrease the hemorrhage and the bleeding that we see on the right-hand side as well. Panretinal photocoagulation would, in theory, sound like it's useful here. It's mostly reserved for neovascular complications, for proliferative diabetic retinopathy, as we've seen. It's not really used to treat macular edema. So CRVO pathophysiology, this is venous thrombosis leading to that hemorrhage and edema that we've discussed. Key risk factors again, age, hypertension, diabetes, hyperlipidemia, thrombophilia, hyperviscosity syndromes, very important to consider, as you would with any systemic cause of thrombosis as well, whether that is a DVT or a PE. The risk factors are pretty similar. And so we're seeing a trend here when it comes to risk factors for a lot of these retinal conditions. That appearance on the right-hand side that we see with our fundus or slit lamp is that classic blood and thunder appearance. So if you see an SBA mentioning a blood and thunder appearance on fundoscopy in a UKMLA exam, it's quite likely pointing towards CRVO. Presentation and investigation. So we get this painless blurred vision with variable severity. And once we perform a fundoscopy itself, we end up seeing these dilated tortuous veins, these widespread hemorrhages. These veins look like they've got high pressure. You can kind of tell from the fundus itself. On top of that, we can do a bedside ophthalmic examination. That's very important. We want to do fundoscopy, slit lamp, as we've mentioned. Tonometry is very important to assess the intraocular pressure here, as our vessels are under more pressure due to the poor drainage of the blood. And of course, if we ever want to assess macular edema, we can do the optical coherence tomography investigation we discussed previously to try and assess for that macular edema. A thrombophilia screen, if we're considering more systemic causes of this thrombosis, would also be useful to consider. In our management, if we have macular edema, we've already mentioned anti-VEGF is first line. If we have neovascular complications, then our PRP can be of use. And alongside all of this, we'd want to treat the patient systemically and make sure that we're controlling risk factors like hypertension, diabetes, and hyperlipidemia as well. And interestingly, so what differs between other VTE management like DVT and PE is you would anticoagulate the patient. That is not indicated here, even though this is often due to thrombosis. So that brings to an end the conditions that we've covered. So we've covered a wide variety of retinal conditions. We've covered things at the level of the UKMLA, but also on top of the UKMLA, there's been some information that may be useful for you to understand, better understand the condition that may not necessarily come up in the exam itself. When it comes to the UKMLA itself and OSCEs going forwards, having a triage pattern is quite helpful, because often with these questions, they tend to focus on pattern recognition. So if a patient has flashes and floaters with no visual field defect, you're automatically leaning more towards PVD with a risk factor of retinal detachment there as well. If a patient has this curtain descending over their vision, or they have a new visual field defect, in that context, we're thinking of retinal detachment. We also want to think about ruling out stroke, TIA as well. If we have sudden profound monoocular visual loss that happens all of a sudden, we're thinking about CRAO. And in that context, we also want to consider GCA if a patient has those risk factors. And if we start to get this central distortion of straight lines and patients not being able to recognize faces, these are the classic clinical vignette words that they would use for a patient with wet AMD. So these are some of the key buzzwords to remember that frequently crop up in exams year after year. That's all. Thank you so much for your time. If you can fill out this feedback form, you will get a certificate as well for your attendance of this particular session. I will also send this feedback form round so that you've got access to it as well. It shouldn't take more than a couple of minutes to fill out, so I will leave this on the screen for a moment for people to scan. And we can also try to answer any questions that people may have. So let's get rid of this screen sharing for a moment. Fantastic. If anyone's got any questions, please feel free to fire away. We'll keep the recording, the live stream going for a few more minutes. And just to let you guys know as well, on top of the session today, there will be 3 to 4, maybe more sessions also covering the remaining conditions from the UKMLA curriculum map as well. So keep a close lookout on socials for Mind the Bleep for those. Keep a close lookout for the newsletter if you subscribed. You will also have those sessions coming your way with links to join them. And be sure to fill out that feedback form so that you get access to your certificate as well. Okay, thank you so much for your time, guys. That's the end of the session. I hope you have a fantastic evening and hope to see you all soon.